but what I'm going to give you is more of a physician's perspective on the disease, whereas Tom's focused predominantly on the surgical aspect. So let me start by asking the question, why do people get ovarian cancer? So all cancer is genetic. Cancer occurs because mutations happen in a normal cell. And those cells that develop those mutations then acquire the characteristics that we associate with malignancy, with cancer. So an ovarian cancer cell, for example, should not be able to survive in the bloodstream. It only can because it has mutations. An ovarian cancer cell should not be able to spread to the peritoneum or the omentum and survive there. It only can because it has different mutations. Without going into genetics in too much detail, we broadly categorize genetics into somatic genetics and germline genetics. So germline refers to the genes we inherit from our parents and that we carry with us in every normal cell in our body. And its variations in these germline genetics can contribute to why certain individuals get ovarian cancer. And we're learning more and more about that. And I think in the years ahead, we're going to learn a lot more about genetics and know more than we do currently, which is limited to BRCA1 and BRCA2 largely. So can ovarian cancer be prevented? So before we get on to talking about the treatment of ovarian cancer, let's focus on prevention. So prevention is a very powerful approach in medicine, and it's been said that an ounce of prevention is worth a pound of cure. And I'm just going to share this William Blake poem with you, which talks about a different cancer. And it says, when my mother died, I was very young, and my father sold me while yet my tongue could scarcely cry, weep, 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 so your chimneys I sweep, and in soot I sleep. And so he was quiet on that very night, as Tom was a-sleeping he had such a sight. The thousands of sweepers, Dick, Joe, Ned, and Jack, were all of them locked up in coffins of black. This refers to chimney sweeping in the 18th century in London, when young boys were sent up chimneys. And they got these terrible growths in their scrotum. And these were poor kids, and it was thought at the time that this was an early manifestation of syphilis. And it was a British surgeon advocated strongly on their behalf, and he believed there was an association between something in the soot and this disease that the young boys were getting. What they had was scrotal cancer. He led to legislation being introduced in the UK that banned chimney sweeping. And what we saw after that was scrotal cancer disappeared, and we never ever see scrotal cancer anymore. So this shows the power of prevention. If you can identify people who are at risk and why they're at risk and remove that causative agent, you can prevent cancer. But while we haven't got as powerful tools in ovarian cancer, if we can identify women who are at a significantly increased risk of ovarian cancer, we can prevent it. And myself and Tom work regularly doing this together, where I see a woman, and because of her specific genetic makeup, she's referred to Tom, and once she's at a stage in her life that she can consider it, Tom removes her fallopian tubes and her ovaries, and that is a very successful approach at preventing women who are genetically predisposed to developing cancer. So that's what genetics is about. It's about identifying among the crowd who are the women who are genetically predisposed to this disease. So this genetic testing has got a lot of coverage in the lay press recently, and Angelina Jolie did a very brave thing, I think, sharing her story with the world, which for the large part, I think, helped people better understand genetics. So it's usually discussed in the context of breast cancer, but this has at least as much relevance for ovarian cancer. And these are the kind of families that we look after in the Mater. And this is one such family. And you can see there's a number of women. So for anyone who's not used to looking at a family tree, circles are women and squares are men. And this was the woman that I looked after. But you can see in her family there are other young women with breast cancer, and she's a relative out here with ovarian cancer. And this woman turned out to have a BRCA1 mutation, and she went on and had her surgery with Tom. So families that carry these mutations are characterized usually by multiple generations affected with cancer. An important point is that men and women can share these mutations equally. We all carry BRCA1 and BRCA2 genes, and we can therefore all carry mutations in these genes. If an individual carries one of these genes, there's a 50-50 chance of them passing it on to their children. And I'm not going to go into the biology as to why people get earlier onset cancer. So the average age of ovarian cancer diagnosis is 68 years of age in the general population, but in people who carry these mutations, the age is a little bit earlier, and that's why we intervene with surgeries earlier. And this more refers to breast cancer, but if you carry these genes, you're at a slightly increased risk of getting cancer in both breasts as opposed to one. So it's obviously a big deal if you carry a mutation in either of these genes, and some women describe it as feeling like there's a fate hanging over them. And I think that this picture, the sordidimiclase, demonstrates quite well how people can feel when they carry these mutations. And counselling plays a big role in the care pathway of women, and other lifestyle factors such as fertility are big factors in deciding as to when is the appropriate time to consider removal of the ovaries. So I think you're already getting an idea that increasingly ovarian cancer is managed by a multidisciplinary team, and every Wednesday morning at 7 a.m. Tom and I meet with our colleagues in the matter, and these are the other people involved in the multidisciplinary team to help women make these decisions under our care. So Tom touched on stage, and this is the most, so if we put ovarian cancer prevention behind us now and focus on treating ovarian cancer, this is the most important piece of information for us in the clinic in helping us to decide how to treat someone with ovarian cancer. And as Tom described, it refers to how widely spread the ovarian cancer is. Has it left the place it started in the fallopian tube, and has it spread locally to the ovaries or more distally within the body? And Tom described this staging that we use, this stage 1 limited to ovaries, 2 limited to the pelvis, 3 to the pelvis and the abdomen, or 4 extending beyond the pelvis and the abdomen. The relevance of that is, if you look at the bottom line here, if you have stage 1 or 2, 70% of women are cured. For those who aren't cured, the time that the cancer tends to come back is usually within 18 to 35 months. Even with more advanced disease, and Tom showed some very extreme examples of the surgery that he undertakes to try and cure women with more advanced disease, cure is possible. Long-term survival is increasingly seen as our treatments improve. And again, if the disease is going to come back, it typically comes back within 18 to 24 months. The key here is Tom being able to get out all the disease. So the optimal debulking is another important term. So stage is one very important term, another is optimal debulking. And what that refers to is the surgeon getting out all the cancer. And you can see the difference in survival. If a surgeon can achieve that, it's almost half if the cancer cannot be removed. The other characteristic of the cancer that we discuss is the grade of the cancer. And what the grade refers to is what the cancer looks like under a microscope. And this is ovarian cancer under the microscope. We graded it, we categorize it into one of 3 grades. Grade 1 being a relatively benign appearing cancer, so it looks quite similar to normal ovarian cancer or ovarian cells. Grade 3 is a cell that has acquired a lot of those mutations that I referred to earlier and become quite different looking. This here is an example of a grade 2, so it's somewhere in between. And that relates to the potential aggressiveness of the cancer if not treated. This is another cancer, or another question I commonly get asked. So we have 3 treatments for any cancer. We have surgery, we have radiation therapy, and we have systemic therapy, which is what I do. Systemic therapy can either be chemotherapy or hormone therapy, or there are some other immunotherapies that are now available to us. But radiation in general is a treatment approach that we don't use for ovarian cancer. ovarian cancer is not that susceptible to radiation therapy, and on the flip side, tends to be very susceptible to chemotherapy. So for after surgery, chemotherapy is the main treatment. So what is chemotherapy? In general, it's a drip that women get in our day wards, and you sit in an armchair, and many of you are familiar with it. It can take anywhere from half an hour to 4 hours to get that, and you can get it anywhere from once a week to once every 3 to 4 weeks. We do have oral forms of chemotherapy now, so there are chemotherapy tablets. And what chemotherapy does is it acts on the cancer cell. In fact, it acts on all fast-growing cells in our body. And that's why people get side effects like hair loss. Hair is fast-growing, nausea and vomiting. The cells lining your gut are fast-growing. And the chemotherapy attacks all these fast-growing cells. The fastest-growing cells are the cancer cells. And it's quite a basic hypothesis that chemotherapy is based on. So you give large doses of this drug, and you try and reach a balance where you're killing more cancer cells than you are normal cells. And then you repeat that, and ultimately, hopefully, have killed the entire cancer cells that are left, and then the normal cells regenerate, and the hair regrows, and the lining of the GI tract regrows. And these are all the different drugs that are available to us now for ovarian cancer. So the two most important ones are the oldest ones, the two in black there, carboplatin and cisplatin. But almost every year, and there was a break in kind of the mid-2000s, but in the past 2 years, we've had more drugs licensed again, but almost every year for the last 15 years has been a new drug licensed in ovarian cancer. And hopefully that is going to continue, and I can tell you from attending international meetings that there are a lot of exciting developments, at least being investigated in ovarian cancer. And we can discuss them later if you want. So how do we know chemotherapy works? And the reason we do is we do studies like this, and this was the first study that showed chemotherapy, one of the first, not the first, chemotherapy worked. And we treat large numbers of patients. On this study, they treated 224 women with chemotherapy after their surgery, and 224 women got no chemotherapy. And this is the effect. So you can see the difference between these lines represents the relatively modest benefit of chemotherapy. And that reflected that about 15 to 20 women were alive in the chemotherapy arm. More women were alive in the chemotherapy approach versus the women who didn't get chemotherapy. And this has been built upon since that time. So that was the early 90s when that study was done. And newer drugs have been added, and combinations and different ways of administering the drugs have further improved the outcome. So why do we choose different drugs? If we have that list of 20-odd drugs, why do we choose a particular combination? And again, there's been lots of meticulous studies done, and this is one such study comparing different combinations and different regularities of administering chemotherapy, and whichever wins tends to be the one that we translate into clinical practice and treat women with in our day ward. Well, in that day ward, how do we know chemotherapy is working? So we predominantly use 3 parameters. The first and most important is the woman herself, how she's feeling. And if chemotherapy is working, in general, in ovarian cancer, people will feel better. So we generally start chemotherapy because a woman is symptomatic. So a woman has a distended abdomen and has discomfort, and, or whatever the symptom may be. If the chemotherapy is working, we should see that symptom improving. The other 2 things we use are the CA125, again, a term that many of you have heard. That's a protein. So what ovarian cancer does is as it grows, it produces this protein, and it secretes it or dumps that into the bloodstream. And we then take a blood test and measure the level of that protein in the bloodstream. An ovarian cancer that is very active will be producing more of that protein. A less active ovarian cancer will be producing less of that. So if an ovarian cancer is dying in response to chemotherapy, that protein falls and your CA125 number falls. And the third thing is CT scans. And Tom showed you some images on CT scan earlier of ovarian cancer. And if chemotherapy is working, we like to see things shrinking on CT scan. And again, Tom touched on this. Where can it spread to, and what happens if it comes back? So if someone has had their surgery and they're being followed up with a 3-monthly and ultimately 6-monthly schedule, how do we know it comes back? And we use those 3 parameters again. We use the patient, so clinical exam, CA125, and CT scan all help us detect this cancer when it recurs. In general, if it comes back, excuse me, in general, if it comes back, chemotherapy is the approach. As Tom illustrated at our multidisciplinary meeting, we oftentimes painstakingly try to confirm if something is isolated and that might be resected with a view to curing a woman of ovarian cancer with surgery. So when do you get the all clear from ovarian cancer? So you're going to myself and Tom every 3 months, every 6 months. When can you finally stop worrying about this disease? And that's a very difficult journey for any woman with this disease to go on, and it's something that everyone has to learn to do. So once you're finished that treatment and you come in and you're feeling well and your CA125 is normal and your CT scan is normal, you still have that fear and it still hangs over you. What I try to help people do is to compartmentalize that fear and leave it in my office or leave it in Tom's office and get on with their life. And most people do manage that. I think coming back to see us often brings it out again. But those figures that I showed for the different stages, once you get to the 18-month mark after surgery, the chance of it coming back is very low. And with each 3 and 6 months after that, it diminishes quite significantly. So by the time you're at the 2.5, 3 years post your surgery, the chance of this disease coming back is very, very slim. So what's ahead? So we are at a juncture in cancer care where we have unique opportunities that we have not had before, and really what has brought that is considerable technological advances over the past 4 to 5 years. We can now interrogate a cancer cell like never before and understand why it grows and why it spreads. And that is being done, and there are huge international efforts that people in the city are participating in. But that, as yet, is not translating into new treatments, and that's where it's somewhat frustrating for us caring for women with this disease, and for women who have it or family members who have this disease. We want that progress to come even quicker, and it's not that we're not trying. So every time we go to meetings and research is presented, and I consistently, every 6 months now, there are new drugs presented. But I do believe it will translate into new progress. I think over the past 6 months or 2 years, really, the two things that we've seen is that we're starting to alter how we give our chemotherapy, and we're giving it a bit more regularly, and that is more effective at killing cancer cells. This drug, bevacizumab or Avastin, is now increasingly being used in ovarian cancer and represents some progress, and some women can do very well on Avastin. Where the real progress is going to be made is when we truly understand the genetic mutations that are driving your ovarian cancer, and we can target that with specific drugs that are personalized to your ovarian cancer. And that right now is not a reality, but for the first time I think it is a possibility. And that's what this refers to. And just to give you one example of where that is going. So this is a drug called a Parp inhibitor that there was a lot of excitement about 2 years ago. And Parp inhibitors are tailored to women with BRCA mutations. So there was a company made what they called a Parp inhibitor. And this is one woman. So you can see that this was her tumor before she got treatment on this side, and this is the tumor after treatment. So this bit had gone, and this one had shrunk considerably. And that brought a lot of excitement. This was the first case to show that response. Subsequent studies with this drug were disappointing, and it turned out that it actually wasn't a very effective Parp inhibitor. It didn't target this alteration that was causing the cancer cells to grow. And there was a lot of disappointment after this story 2 years ago. Well, the pharmaceutical companies went back to the drawing board, and they've now come back with better PARP inhibitors. And there's a whole flurry of new studies starting. And I'm actively trying to get one for Irish patients. And hopefully we'll be successful in opening a clinical trial of a PARP inhibitor soon in this country. Currently, we don't have one. So let me finish with this quote by Voltaire. So, doctors are men who prescribe medicines of which they know little to cure diseases of which they know less in human beings of whom they know nothing. So despite what you may think after seeing myself and Tom present today, doctors are no longer all men. We've made progress in that area. We've learned a lot about the diseases, and we've learned a lot about the biology of ovarian cancer and why it grows. I think what we're now starting to learn a lot about is the women who have this disease and our biological makeup and what causes us to get different diseases. And I think those two pieces of information, better understanding of the biology of ovarian cancer and better understanding of the women who get ovarian cancer, will give us power to both prevent better and to treat better than we currently do. So in that regard, I'm optimistic for the future of ovarian cancer care. So thank you. I think we're going to take questions from the floor. I've certainly some that have been sent up to me.